Rice University. His work is targeted at eliminating disparities in health-related behavior through translational research. So he starts with theoretical models of addiction and cancer risk behaviors. He then uses those theoretical models to develop interventions, and then he actually develops these interventions and introduces them out into the real world. So you could say his research spans the continuum from cells to society and focuses on high-risk and underserved populations with a major focus on low socioeconomic status individuals, minorities, and women. So we were very lucky to be able to lure Dr. Wetter from MD Anderson. It's his second year here, so you may not have seen him much, but you will certainly see more of him around on campus. His professional service includes serving as chair of the Community Level Health Promotion Study section at the National Institutes of Health. He contributed to the report of the Surgeon General on reducing tobacco use. He was member of the editorial board for health psychology, scientific consultant for 2 U.S. Public Health Service tobacco treatment guidelines, program chair for 2 annual meetings of the Society for Research on Nicotine and Tobacco, and chair of the Cancer Forum of the American Public Health Association, and of course invited participant in numerous NIH work groups. As you can guess, Dr. Wetter has a substantial NIH-funded grant portfolio, over 170 peer-reviewed publications. His research program has received awards from the Society of Behavioral Medicine, the American Society for Preventive Oncology, the Health Psychology Division of the American Psychological Association, and of course, Houston's own Texas MD Anderson Cancer Center. In addition to his research awards, Dr. Wetter was the inaugural winner of the Leading Mentor in Cancer Prevention and a winner of the Robert M. Chamberlain Outstanding Mentor Award in his previous position at MD Anderson. So with that, David.
Good afternoon. It doesn't seem fair to have to follow Rebecca, but nevertheless, I'm excited to be here and to tell you a little bit about our work. And in particular, I'm going to focus on the really powerful role of context on human behavior. And we're very interested in real lived experience, like in the moment, in the real world. And so we're going to try to get a little bit to that. And the specific case example I'll use today is around the role of the social determinants on influencing smoking cessation. So first, since this is my very first talk to all of Rice, I'm going to take just a minute and tell you a little bit about the research foci in our lab, and then why we study tobacco and the social determinants of health, tell you real briefly about modeling some of the links between social determinants such as socioeconomic status and a specific smoking quit attempt, show you a little bit about some of our work showing how powerful context is influencing those quit attempts, and then give you a little brief summary. So the Health Outcomes and Population Equity Lab, I won't go through this very much. Vivian just told you some of this. We focus on health risk behaviors with a very specific emphasis on reducing inequities in those behaviors. We use what we call the 3 T's, a translational, transdisciplinary, team science approach, meaning we want our research to have real-world impact. We try to utilize experts from a huge variety of disciplines, genetics, engineers, computer science, geospatial scientists, etc. And then we try to make sure that it actually happens in the real world. We use a wide variety of methods. We use smartphones to assess real-time subjective experience. We use on-body sensors. We do GPS tracking every 5 seconds in some of our new studies. We use census measures. We get genetics, etc. It's a lot of this real-time stuff is very Big Brother-ish if you think about it. So we use those models that we learn from those data to create interventions and implement them. We've developed a number of intervention approaches over the years. And then always with, in our interventions, in partnership with real-world systems, healthcare systems, patient navigators. We've done some policy work, etc. So why focus on tobacco? And it's pretty simple. It's the leading preventable cause of death and disability in the U.S. We could eliminate almost 1/3 of all cancers if we eliminated tobacco use. And we all think drug abuse, homicide, suicide, risky sexual behavior are major public health problems. Tobacco kills more people than all of those combined. It's also highly prevalent. And that's something that I think is getting lost right now, is the fact that we have not solved the tobacco problem. We have moved it to vulnerable populations, but it's an incredibly highly prevalent risk factor. There's good news and bad news. The good news is the vast majority of smokers want to quit. Over half make a quit attempt each year, but less than 5% of smokers actually quit every year. And we're doing a great job of replacing them with young people. So we're not seeing much. We're seeing a very, very stagnant, slow decline in prevalence of tobacco use. If we're successful in reducing tobacco use, though, we have a huge public health impact. You know, the 1964 Surgeon General's report that first linked tobacco to lung cancer led to a lot of public health campaigns to reduce tobacco use, and we were successful in doing that. That led to a reduction in cancer in the 90s and early 2000s, of which over half of that decline in cancer deaths was attributable simply to reducing tobacco use. It was not due to fancy new drugs, fancy new technologies, etc. It was simply due to reducing tobacco use. So if we can be effective in reducing risk factors, we have an enormous impact on public health. Why do we focus on the social determinants of health? And social determinants is actually probably not an accurate term. It's really social correlates of health. But what do we mean by them? We mean the conditions, the economic conditions, the social conditions, the built environment conditions, the physical environment conditions that we all live in, work in, age, etc. It's really context. And there is a profound gradient in morbidity and mortality attributable to the social determinants, worldwide and in the United States. And I was hesitant to put this up there, but last week a really intriguing study came out which suggested that the role of context is much more powerful in low socioeconomic status populations. So in populations that have lots of resources, etc., genetics, for example, can allow people to bloom to their full potential. When you're in very low resource kinds of settings, genetics plays a much smaller role, and we can kind of come back to that a little bit later. I think of it as planting seeds. A quality seed versus a seed that's not as quality. There's probably not much that you can do when you're trying to grow it on a rock with no water. So context then plays a huge role and seems to be perhaps a larger role in low socioeconomic status populations. So I'm going to tell you just a little bit about one aspect of the social determinants, which is sort of some economic aspects here. And we call it socioeconomic status in the US. We use a wide variety of economic sort of indicators to assess socioeconomic status. And I want to show how the simple little indices of economic resources influence a very specific smoking quit attempt. And this is in all of our studies that follow this sort of protocol, we fully treat people. So inequities due to economic resources and other things are never due to differences in access to care. They are never due to differences in the quality of treatment. They are due to other factors. So let me take just a minute to walk you through this, because I'm going to show you 4 different ones. So on the vertical axis is simply the number of people that are able to successfully quit, the percent that are able to quit. On the bottom is 2 different time points, 4 weeks after a quit attempt, 26 weeks after a quit attempt. And in all of the graphs I'm going to show you here, the red line is always the more advantaged group, and the blue line is always the more disadvantaged group. So in this one, you can see that if you divide this group of smokers who are trying to quit based on a total household income of less than $20,000, which less than we pay many of our grad student stipends, as its total household income, you see that it has a big impact on their ability to quit. They're all getting the exact same treatment. You see the same thing if you look at education. If you look at whether they have insurance or no insurance, and when you look at whether they're employed or unemployed. So all of these various indicators of socioeconomic status play a big role in a very specific smoking quit attempt, not over long periods of time. This is over a relatively short period of time. So why is that? So we were interested in sort of modeling what pathways lead to, from low socioeconomic status to an inability to quit in our studies. And there's some common mechanisms that are proposed by a wide variety of theories. Very simply, it boils down to if you're low SES, more bad things happen to you. You experience discrimination, chronic stress. You have less access to good things that buffer the effects of the bad things, such as social support, social capital. If more bad things happen to you and fewer good things, that affects how you think. It affects your motivation. It affects your emotions. And then that affects your ability to change your behavior. So we started to try to model this out a little bit. And I'm not going to walk you through all this. Let me just say, though, that everything in this model, this is a structural equation model, every pathway, every line in this model is significant. The model holds, this was a tri-ethnic sample, a third, African American, Latino, white. The model holds across every different racial ethnic group. And I want to sort of just draw your attention to a couple of things. So, and we're going to focus just a little bit right here. I'm not going to lead you through all this. I don't have time. But I want to focus on this one specific piece of neighborhood disadvantage. You can think about neighborhoods in a variety of different ways. So you can think about them, and I'm calling this macro context and micro context, but please don't hold me to that because I just made it up. Because I'm going to talk about sort of larger neighborhood things, and I'm going to talk about micro context, which we often think of as in the moment, what's happening right now, both intrapersonally and interpersonally. But you can think about neighborhoods, socioeconomics, social factors, and built environment. And so to envision this, I want you to think about two neighborhoods. I want you to think of one a mile west, West U, and one a mile east, Third Ward. They have very different economic profiles. They have very different social factors, levels of crime, trust in your neighbors, belief that you share the same values as your neighbors. They have completely different built environments. In West U, you have H-E-B flagship, Kroger flagship, Randall's flagship. All those places, for example, sell tobacco. You don't even know where they are. In Third Ward, you don't have any of those. You've got mom and pops on every corner. And in those, the windows, I'm going to show you a picture here in a little while, have nothing but tobacco ads on the windows. The windows are covered with those kinds of things. So incredibly different built environments. Third Ward, decay, boarded up windows, lack of lighting, no sidewalks. West U, beautiful. So neighborhoods, and how does that play out in your ability to make a change in your behavior? So let's go through each one of those. Just give an example. So here is unemployment. This is a sample of 400 African American smokers, again, get treated by us, etc. And we looked at individual level unemployment, and we find the same thing we always find. So this is the employed group. This is the unemployed group. This is all of these graphs are going to basically kind of look the same, with abstinence plotted on the vertical, time on the horizontal. And so you can see that whether they're employed or unemployed makes a big difference in their ability to quit. The next thing we did is simply look at where they lived, and we classified their neighborhoods into quartiles based on the neighborhoods that had the highest level of unemployment and those neighborhoods that had the lowest level of unemployment. We controlled for all the individual level socioeconomic status factors, including unemployment, and then we looked at whether simply living in a neighborhood that has a high level of unemployment versus a neighborhood that has a low level of unemployment makes a difference. And what we find is it's patterned exactly as you would expect it to be patterned. This is the neighborhoods. These are the individuals who live in the neighborhoods with the lowest level of unemployment, second quartile, third quartile, and the bottom quartile, meaning the neighborhoods that have the highest levels of unemployment. This is just whether your neighbors are employed or not. This is not even you. We're controlling for that. So again, context, very, very powerful. We also looked at social factors in this same thing. And we looked at a factor that's called social cohesion, which is related to, if people have heard the term social capital, it's the trust you have in your neighbors, it's the belief that you share the same values, that you can go to them if you need help. And we did the exact same thing here. We patterned people's neighborhoods on quartiles, highest levels of social cohesion, the lowest level of social cohesion. And we find that, again, the patterning of neighborhood social cohesion and abstinence is exactly what you would expect it to be. And it matches the objective indicators of economic status in the neighborhood as well. And then finally, let's talk about the built environment. And so this is not a third ward convenience store, but this is the kind of store that's typical of a lower SES neighborhood. And I want to point out what's advertised in the window of convenience stores in a low SES neighborhood. Cigarettes, cigars, e-cigarettes, booze, and gambling. So, can you think of any of those plastering the windows of the HEB flagship? Maybe there's a lottery sign stuck in there somewhere. But huge differences in the kinds of environmental stimuli that are there simply in the built environment. We also know that there's a much higher density of tobacco outlets, alcohol outlets, etc. in lower SES neighborhoods. So we simply looked at a couple of different things. We wanted to look at how close they lived to a tobacco outlet and whether that influenced their quit attempt. But it sounds kind of crazy, right? That how close you live would make a difference. But what we found when we did that is that indeed, simply the closer you live to a tobacco outlet, the more likely you were to relapse. This is after controlling for all the other things. This actually, if you know addiction theory, makes a lot of sense for many, many reasons. Cue reactivity, the ability for cravings to wax and wane over time, but really interesting. So the next thing we did then is look at, when we do these self-reports on your smartphone, we simply looked at where they were when they did the self-report. So with a GPS locator. And so we looked at their level of craving that they reported on the phone, and we looked at how close they were to a tobacco outlet. And what we found was that the closer they were to a tobacco outlet, the higher their craving, but only in their neighborhood. Not when they're outside their neighborhood, which actually you can make, post hoc I can make sense of anything, right? So speculatively, you could think that people have mental maps of their neighborhoods. They know where things are. And I'm not thinking they're having this conscious thought around that, but it's a very intriguing notion that simply there's lots going on as we travel through our world and how that context influences really basic sort of processes in human beings. We have done this now with homeless individuals and seen the exact same thing when we look at the proximity to their homeless shelter and their negative emotions. So the world has this really, really powerful impact. Next thing I want to talk about a little bit is sort of, we've done a lot with smartphones in the past. A lot of our new work is now all this on-body sensors and 5-second, we get a GPS locational signal, etc. But I want to talk, so there's a whole strategy of approaches for doing this kind of thing that's called ecological momentary assessment. And so we use smartphones to get subjective experience. We're using, wearables, which are proliferating everywhere. I don't know how many of you how many of you got a Fitbit on? I've got a Fitbit watch. Your phone is doing GPS all the time. We're actually doing physiology as well. So it's a great way, and it gives us opportunities we have never had in the past to assess real-time, real-world lived experience, all the way from physiology to self-report to place, etc. So I want to just show you one of our first studies doing this, and it's a very, very simple kind of analysis. We know in poor neighborhoods that they have, there's a higher prevalence of smokers, so other people smoking. We also know that the major mechanism that is hypothesized in many models of linking SES to health risk behaviors is through stress and negative affect. And then we also looked at alcohol because it's something we're interested in. So we took, every time they do an assessment on the phone, we looked at that situation. And we classified that situation on whether there were other people smoking, whether they were experiencing negative emotion and stress, or whether they were drinking alcohol or not. So every situation goes from they've got 0, none of those triggers present, to 1 of those triggers, to some combination of 2, to all 3. And we looked at the proportion of each situation that resulted in a lapse, meaning they smoked. And remember, they're all trying to quit and stay abstinent. And here's what we found. If there were no triggers present, 0.4% of those situations resulted in a lapse. If there was 1 trigger present, anywhere from about, little less than 1% to almost 3% of those situations resulted in a lapse. 2, it goes up again, and then 3, it goes up again. So if you look at this in relative terms, if there's no triggers, your odds of that situation resulting in lapse is 1 out of 250. If all 3 triggers, the odds that it'll result in a lapse is almost 1 out of 5. So really powerful influence of what I call microcontext. But again, I'm making it up, so please don't go look that up anywhere. So the other thing, using this, we can also because we do this repeated measurement multiple times a day over multiple days, we can actually look at trajectories of lived experience, both in a very specific time period, from a few hours to a day to several days to weeks. And we can calculate trajectories based on those. So for example, if you just take 2, I'm making these up. These are just examples of two different patients. Patient 1, patient 2, and you can see that they differ on their trajectories in many, many ways. They differ in the mean level of the, whatever variable we want to call it. They differ in the slope over time. They differ in the volatility. And we've looked at those trajectories now to see if they're related, these trajectories of real-world experience are related to relapse. And what we find is that they are indeed for almost all the major mechanisms that we hypothesized to drive relapse. We see differences based on trajectories. And so this is we see them over very short periods of time as well. So for example, a very rapid rise in negative emotion predicts a much greater lapse, likelihood of lapse later in the day. We've done a bunch of stuff here that's actually really interesting, I think. So with the new sensing stuff, now we're actually able to, most of this is based on the subjective experience. We're now, with the sensing, actually able to start to clarify what's happening in these situations, many times unobtrusively. So meaning the person doesn't have to tell us anything. We're actually measuring negative emotions unobtrusively, without self-report, based on physiology, obviously place. We can tell whether they're interacting with somebody, whether they're smoking, whether they're eating, whether they're drinking, etc. And then, so just to sum up, inequities in health behaviors have a huge public health burden. And it's something that we've really got to address in the US. And inequality in income is one of the major driving factors there. And in fact, in smoking, we see that, a really profound gradient in smoking prevalence, the ability to quit, and morbidity, mortality by socioeconomic status. And I want to just highlight this right here. There's been an analysis looking at how much of the SES gradient in health can be accounted for by tobacco use in 4 English-speaking developed countries: the US, UK, Australia, Canada. And between 50 and 60% of that SES gradient among males was attributable entirely to tobacco use. Meaning if we could eliminate inequities in tobacco use alone, we could dramatically reduce that SES gradient in health. The last thing I want to talk about, or not the last thing, but one of the things that I think is really critical here is the reason so many people don't think smoking is a prominent problem anymore is because we have now pushed it into vulnerable populations. 50 years ago, in the early 60s, y'all would be smoking right now, and about 50% of the men would be smoking right during the talk. Now, there's probably not anybody who will raise their hand and admit to being a smoker. There must probably a couple closet smokers, but what's happened to smoking is we have now shoved it into really vulnerable populations, those living in poverty, those with psychiatric comorbidities, etc. So we had this fantastic public health advances in reducing overall tobacco prevalence in the US, but not all segments benefited equally because we did not pay attention to how to reach really vulnerable, underserved populations. So as we go forward, we have to do that. Vulnerable populations are always the last, with the exception of Rebecca's work, always the last to benefit from any kind of new drug, new technology, new anything. They're always the last to benefit. So we've got to make special effort to reach them. And then finally, I spent 18 years at MD Anderson where, there's a giant biological institution and always, we know genetics and genomics. We don't need to worry about context anymore. We're going to solve all the world's social ills and health problems because we know how we can map the human genome. And I like to point out that, context is still huge. It has a really powerful effect. And I can show I love showing my genetics people the effect sizes because we can beat their effect sizes. So, and then finally, really quickly, why does anybody care about developing these kinds of comprehensive conceptual models? And the reason we care is that it has a really profound influence and implications for how we're going to intervene. So as we understand these really acute precipitants of lapse, it can help us in designing, apps that go on your phone in developing better rescue medications for sensor-based interventions that fire off when they see congestive heart failure, lungs filling with water, etc. As we understand these larger pieces, we can develop pharmacotherapies and behavioral therapies that are better matched to specific individual profiles. Context is obviously huge. Our work there on tobacco outlet proximity says maybe we shouldn't allow tobacco outlets in retail neighborhoods. We already zone. You don't get to have sexually oriented businesses in residential neighborhoods. Maybe we shouldn't be allowing tobacco either. And then finally, jobs programs, early education, those kinds of things if we really want to attack the core social determinants of health. And then finally, again, as I started, this is really team science. I have a very narrow range of expertise. And so we steal everything from everybody else that do a wonderful job. So, and that's it.
Okay, thanks very much. So we have plenty of time for questions and answers. We're going to go to 5:15. If Rebecca and David could come up here, you can field questions from the microphone, and Rick's going to be wandering around the room with the...
I have a question for David. Even the high socioeconomic groups fell off precipitously over time. Clearly, there's not as many left in the high. You've had a lot more people probably quit over the last 20 years in that high, but the ones that are left, what is driving that? Is it?
Oh, we can get people to quit with really good treatment for a while. Relapse is the defining sort of bugaboo left in addiction treatment. We can get people to quit using drugs. We have not been able to successfully stop them from relapsing down the road, particularly when treatment ends. So that's what you see there, why abstinence rates are always high at the beginning and decline over time. And what you actually see in the effect sizes for the context and social determinants effects is they actually get larger. They're larger at the later follow-ups than they are at the beginning. The absolute differences look bigger, but the relative differences actually increase over time, if that makes sense. Meaning there's a difference of 10 percentage points, let's say, at week 4, and it's only at week 6, but the problem is we've gone from a 20 and 30, so a 1.5 relative risk, to 2 and 7, which is a 3.5-fold relative risk. So, but that's they all every substance of addiction shows that exact same relapse pattern.
I'm interested in the people that don't relapse. Are there such people, or if the curve goes out long enough that they eventually all relapse? And
No.
and I'm sure those have been studied by other people. I mean, what is special about them? Is it possible to do brain training, or they just have lucky addiction centers in their brain, or what?
Yeah, there's a million. So there is evidence. So in I didn't present it today. We're finding that actually those folks in their real lived experience do have things that buffer against stress. So for example, more positive affect, more social support, etc. The personality, we've looked at personality a lot in addiction. The big 5 personality characteristics are related, for example, to who's able to successfully quit or not, but they don't carry much variance, frankly. It's much more proximal kinds of things that carry the real predictive power. It's higher SES. When the Surgeon General's report came out, all the people that quit initially were all people like you, well-educated, what would be upper middle to wealthy people quit for all the variety of things that are associated with that, both social capital, social cohesion, social support, much less context with much less stimuli promoting addiction. So, but yeah, there's a wide variety of factors that buffer against stress and the ability to quit. So.
One quick question, David, for you. I appreciate tremendously the recognition that we're not talking about social determinants, because these things are so intercorrelated with each other and it's almost impossible to separate. But have you thought about intervening with giving this information to the clients who are going through this program to say, watch out, we know that living near these places with cigarette outlets is a danger, and giving them some self-knowledge and self-awareness of things to watch out for, because we know that this can stimulate a relapse, and we can work with you to make sure that this doesn't happen.
Yeah, so what was it? Not early 80s, there was a called relapse prevention theory, which was all about training individuals in recognizing high-risk situations, having them plan for how they would handle those, figuring out coping strategies that they would use and implement, and having a beautifully laid out plan, and it didn't help us at all. We've got now, 30 years, over 30 years of research on it. Preventing relapse has really been, the biggest problem for us. You had asked about mind training, which, so there are all sorts of different. One of the things that seems to be kind of exciting is the notion of attentional control. And we've actually just finished a NIDA-funded trial where we found that teaching them to do what we call the mindfulness-based addiction treatment, which is, if people then know, mindfulness is all the rage, but it actually helped people better recover from lapses than our very best cognitive behavioral therapy. So I think there are some kind of exciting things that seem to be able to help people recover from lapses, but this one trial, this was our first trial using this. But we've tried to do other things as well. We've made smartphone apps. They didn't work. We've got a whole other counseling approach, which is not focused on helping them recover from a lapse, but what we think of as recycling, which is so that when they lapse, we just have them, let's just start again then and not give up, because there's a common phenomenon in failing any kind of behavior change where everything becomes catastrophic and black and white thinking. And so, I've had this, you think about your own self. I mean, for me, I'm not going to eat any sweets, but dang, I took a bite of cheesecake at dinner, and so now I might as well eat a couple pieces because it's all is lost. So, But we've used a wide variety of approaches, and only one, the mindfulness treatment right now, is the one that seems to have potential for helping people recover from a lapse. Although with the sensor-driven interventions, you might be able to do things now that you never could do before, because you'll know when they lapse. And in the past, you don't know. You never know. So you can't intervene in the moment. So
I want to thank our moderator and both of our speakers. These wonderful talks. I think they were very stimulating and wonderful insights from both of you. And thank you for attending. And I'd like to invite you out to a reception where you can ask additional questions of our captive speakers here. So again, thank you very much, and appreciate